Hi, good morning, everybody. I am first of all thankful to Dr. Srinivas and the entire team at TCT Hyderabad for giving us this opportunity. I am Dr. Aditya Kapoor. I have with me two of our very accomplished interventional cardiologists, Dr. Roopali and Dr. Ankit Sahu, and we have Dr. Arpita here, Mr. Shiv Dayal, Mr. DK, and Ashwini from the Abbott team. So I'll just hand over to Dr. Ankit to quickly go through the history, and Dr. Rupali will discuss the angio shots which have been taken already.
Okay, we have the case slides. So we have a 56-year-old gentleman. He has history of chronic stable angina since past 5 years. For past 1 month, the symptoms have worsened, and for the 2 weeks back, he had a episode of rest pain. He also has a risk factor of tobacco chewer, and clinical examination was within normal limit. Troponin is negative. Can we have the ECG? So ECG have some ST coving, mild ST coving in V2 and some ST depressions in V3, V4. Otherwise, it's okay. Echo is normal. There is no regional wall motion abnormality. EF is within normal limits. Lab parameters are okay. Creatinine is fine. We have the angiography.
So, Ankit, actually, I think we are dealing with your patient with having a recent chest pain with acute troponin negative. And this was an angio we did recently. If you can see, this was done through radial route. And we have a left main, which looks normal. And LCX is a big vessel, but it for sure looks free of significant disease. But if you see the epicaudal view, the LAD was having an osteoproximal critical lesion, which was causing a decreased flow in the antegrade flow in the LAD. It was like a TME2 flow or TME1 flow in distal part, and which was confirmed in other views also. Can we have the next slide, please? So this was the areocranial view, which showed a critical LAD, which was causing a TME0 flow, and which was confirmed in the different views. There was classical osteoproximal lesion, which according to the ECG also we suspected that this people are dealing with a critical LAD lesion. And if you see his RCA was also free of any significant disease, and there was a distal filling of LAD, which was a mild retrograde collaterals, if we can see, which was partially filling the LAD, not very good collateral filling. So we are dealing with an acute setting, not a chronic setting, which led to this. And if he sees LV, like on echo also, we didn't find any regional wall motion abnormality. And this was his LV angio, which was no regional wall motion abnormality with normal ejection fraction. So what should be the strategy which we are dealing with in this 56-year-old gentleman?
Yeah, thanks, Dr. Rupali. Thanks, Dr. Ankit. So, as both of them summarize, this looks like a patient who had some chronic symptoms and has had some recent worsening, isn't it? And if you see the current angio shots,
So can we come to the recent angio? Can we remove the slides and come to the recent angio? Shift to angio.
can you get the angio on the screen? The angio shots. Yeah.
Yeah.
So this is the areocranial, and if you go to the next angio, please. So there seems to be some leader there. So in your opinion, I mean, we have taken the normal EVO guide. What wire should we start with? What would your choice be?
I think it's a recent, sir, which is having a critical stenosis with some, I think, thrombotic occlusion because it's slow flow across the LAD. So we can go ahead with a normal workhouse wire.
Yeah,
And if we can see, the LAD filling is definitely better what it was prior to it.
yeah. Can we up the mag a bit?
Yes, sir.
Somebody give me a test.
Yes, I think we have entered, sir. Yes, sir.
Is in the diagonal, and now we are in the LAD. And can I just see? Is there any forward flow? I doubt.
I think we,
Yeah,
post wire, I think it would have decreased the flow.
yeah.
Yes, sir, as expected.
So maybe you and Rupali can also run us through the fact that if somebody just for discussion sakes wants to say that okay, I just want to do a thromboaspiration at this point of time, so how sort of relevant would that be, or shall we straight away as we are doing, we are going ahead with the balloon?
Sir, actually, thromboaspiration routine practice, I think we still do, now we're going back to it, like we don't have a much data, and this has shown that routine thromboaspiration has led to more complications rather than benefit. So
Yeah,
since we didn't find any grade 4 thrombus in this case, it was just a stenosis critical area. So we can just do a small balloon
yeah,
dilatation and
because the circumflex is right there. So
I think it
did the
slipped.
balloon
So
slip a
yeah,
bit, I guess?
osteal fibrotic
Because
Retest,
lesion.
yeah.
we don't
Yeah.
want to do much
Yeah,
high
yeah.
pressure balloon dilatation because we want to see the plaque morphology in this case. So going very high pressure, we might call dissection, which will be little. It's
This
slipping.
slips a
It's
bit.
slipping, sir. Yeah.
Seems to have created some channel.
Record. Fluoro record.
Test angle. Sorry. Shall we do a bigger balloon here before you proceed for an imaging or what?
I think so. Distal flow we have
You got
achieved
some good.
distal flow. Let us do an OCT. Can we document some
Okay.
plaque morphology? It's
Yeah.
like. So which imaging, Ankit, you want to go ahead with? This IVUS, OCT, or
So
in
ideally,
these ACS
I would like to go
case?
ahead with OCT because plaque morphology is a prime concern. So how to modify the plaque, and if thrombus, we are also suspecting thrombus. So
Hanji.
OCT probably gives the more better picture.
Sir, actually, sir, if you see an OCT and ACS, so we have to look for your one is your plaque
ACT कितना
morphology.
था?
Like if we see, we have a very good data also now from Indian population, which have shown that these either can be plaque lesion assessment can be either due to plaque erosion, plaque rupture, it is a calcified nodule. And if we see there are different
Current किस किसमें
morphologies which has been seen with STEMI and non-STEMI,
अभी डाल
and
दिया
plaque
मैंने
erosion has been found to be more with
अभी
non-STEMI part.
Hmm.
And but then not in our case, but if you have a plaque erosion with good lumen area, then some studies have shown like erosion 3 and erosion trial that you can just keep it on medical follow-up. We don't
Correct.
have to stent these cases.
But here, as we
And
seen that balloon was slipping, so
yes,
probably more fibrotic component would be
agreed.
there.
So we have kind of more a fibrous lesion with having some. I don't calcification doesn't look like angiographically, but
No.
I think more will be on a plaque will be have more cholesterol crystal and macrophages and valuable plaque, which I think we'll be able to see in this case.
I think that's a
The same.
great point you make. Apart from plaque morphology, I think the osteal disease and the osteal placement would be a critical issue. Shall I go ahead?
Yeah,
Can
yeah,
we go
yeah.
ahead?
The OCT is
Okay.
ready.
Flushing.
एक बार
I'm
किट
just
फ्लश कर
going ahead.
2.75
Huh?
or 2.5?
So
Not
we
a great
cannot see the
image.
plaque, but
Yeah.
I think whatever we are getting, it's a
Highly
very
attenuated.
hypoattenuated area. We
Correct.
have there maybe a lipidic,
Lip.
high necrotic core, which we expected also, and
Balloon.
there is some hyperechoic part, maybe crystals
Yeah.
or something. We cannot be, but very not very
Could
very
be a
sure.
suboptimal image as
Suboptimal
well.
image interpretation, so it will be a little difficult to tell us. But if you can see, just go back little, Ashwini,
Sleep हो रहा है
from where you from just where
Balloon
you
पूछो.
came. Go little down at maybe 0
2.5.
degree, zero. Just go down. You're going proximal. Yeah. If you can see in the proximal part, the thin cap. It's like if you see at the 12 o'clock and 11 o'clock part. Yes, sir.
So which cutting balloon is this?
So it is Wolverine 2.510. So we will just, for the inflation part, we have to go very slow,
Mm-hmm.
maybe 2 atmosphere at every 10 seconds,
Right.
so that the blades which are there, they can just open up. And with this part is better slippage of the balloon, that is not there. So because we are just dealing at the ostial, so we don't want to come in the left main and cause any back. So we want the blades to be like rotate in different direction.
Mm-hmm.
So they are like at a 2.5, they have a 3 blades. If you go 3.5, they have 4 blades across it.
Mm-hmm.
So in this way we
And
can.
gives you a more predictable position.
Yes, sir.
And wait for it to deflate and pull it back. Is that okay?
Yes, sir.
Yeah. Inject. Yeah.
Yeah,
seems
so
to
if you can see, we have got very good flow in this LED, and I think now imaging can helps us, but we are not very sure whether we're able to see the plaque rupture or
Yeah,
not because
yeah,
we
we've
might
already
have
modified
the plaque actually.
But as you
So,
said, we made a reasonable attempt, tried to pass in the OCT after the first balloon dilatation. Unfortunately,
okay, sir.
take it out, huh?
Yeah.
Yes, sir.
शाहनवाज एक ACT भी कर लेते हैं यार.
इसको निकाल दो अभी कर लेते हैं
So if we see the, what do you interpret the OCT image?
ACT यहीं से दे दो मुझे.
Okay. So can come the distal part. So we can clearly see the distal part is the bent part. So there is fibrous plaque
Yeah.
which is there, but it is less than 50%. But if you see the artery is quite huge, EL to L is come out 4.5, And the proximally more come, it's a more a necrotic plaque which is seeing hypertenuated areas from 12 o'clock to
It
3
seems to
o'clock.
some dissection there, is it?
There is some to be dissection, sir. Yes, sir. But if we see there is some hanging in the lumen also. Is it a white thrombus which we are dealing with, or is there some dissection plaques? More a dissection plaques, because it's very difficult, sir, post dilatation to comment it's a dissection or
This
a thrombus like
TCT
thing.
lipid plaque.
Yeah, but it is, if you see, it's a more hypertenuatic plaque.
Ashwini, Rupali, what is this? Just go back a bit. This thing which is hanging inside, I mean, would you still call this as a dissection, or as madam said, it could be still be a thrombus or something?
It is casting a shadow behind
Yeah,
onto the vessel
this
wall.
one?
Yeah, this one. So this can be a thrombus.
Yeah,
Throm
looks like, I mean,
hmm? Yeah, actually, sir, post cutting it
yeah.
sometimes become very difficult to
Ashwini
say.
Shadow.
diplomatically agrees with us a bit.
So it is very difficult to say. Most probably it might be we have cut through blades that
Correct. Stent
which is
size and
causing the
everything?
plaque prolapse inside the lumen, and which is giving a little. But the and can you tell the proximal what's the size?
You see? Epicaudal.
Huh? Osteomus disease. So we don't have a landing zone, sir.
Mm-hmm.
So should we come from left main to LAD? I think that would be. Can you tell me the carina? What is the carina at this juncture? Hmm.
But मुझे लगता है, I mean, if you see the epicaudal, can we get away with just
Yeah,
a
we can
dot
have
ostial
a
placement?
we can have a some zone there
Yeah,
because
yeah,
carina
yeah.
looks off the disease. Okay. What is the angle? So I think that's a good thing because that means we good space and there is less chances of going for side branch occlusion.
Thanks.
So that's a technique. Like if suppose the flow gets
Yeah,
stopped,
yeah.
so at least we can just place. I think looks fine, sir.
देखें जरा.
Yeah. So we can just place this in the proximal part distal. If you don't see also, we
थोड़ा
can just.
आराम से सांस लीजिए.
Yeah.
So this looks okay.
Distal areocranial,
Areocranial, then
Areocranial.
aliocaudal, we can just see, sir, for the
aleocaudal, yeah.
proximal part.
Okay.
Yeah,
So
looks good, sir.
distal we are well
Well
across.
interested.
Aleocaudal, Dr. Rupali
Yes, sir.
wanted.
Some in some other view.
So with alpine, it is like if you see the stent, it starts from just at the radiopaque marker. So we can just, because our eyes gets adjusted to that. So if you just see
Correct.
the radiopaque marker, we are sure that our still placement would be good enough for us. It looks good, sir, I think so.
Happy?
Ankit, what you say?
You want a millimeter back?
Yeah, millimeter back.
देखें.
I think
Okay.
it's okay.
Yeah.
I think it's okay,
Yeah,
sir.
okay.
I'm going ahead with it,
Yeah.
sir. So the
Yeah.
4.5 NC.
I'll pull this out.
Yes, sir. So do we have a EL to EL in the proximal part? Can we see that? No, because of the lipidic plaque, we are not able to see the EL, EL. Okay. So it's a good placement. Angiographically looks good. The L6 is not pinched and
Aneurocranial.
see, कौन सा है?
Okay.
ठीक है.
साढ़े और साढ़े चार ले लेते हैं. With pods, there is some new school of thought. It's like if you're going for over expansion in these cases or high pressure, start from proximally and then go distally.
Okay.
Because there has been few case reports. If you start distally, there have been stent elongation.
अच्छा.
So in this case, I think we can start with proximally and then go distally.
Okay. So
We are
looks good.
checking at 4.5, 4 mm. So let's see, and can go up to till 20 atmosphere.
Leaving one strut.
Yeah, we don't want to go distally because I think we have covered that was a soft plaque.
What
which I have
pressure
put.
are you on?
So I'm at 20. Should
Yeah, now it is good.
it's okay? हाँ?
Bifurcation वाला point पे
हाँ,
तू
क्योंकि
कर दे अब तू इंजेक्शन ताकत लग रही है. So distal, I think we got a good clearance. So distal edge is like good, so there is no
Looks
distal edge
opposed,
dissection, well opposed stent struts,
correct.
and good expansion also.
Correct.
But I think the proximal part we didn't have a very good clearance, but we are able to see the stent
Struts
struts, I
हाँ
think.
दिख रहे थे. Yeah, you're right.
here the cell
And
is
bifurcation we are not. I think we can take a one pull back at the mid part from the stent, so at least we can see the
withdraw catheter
bifurcation.
slightly.
तू देना भी injection.
तो मैं
Take a
पीछे
new run. We'll
withdraw
start
कर
from the
रहा
mid
हूँ.
part of the stent.
Happy here?
और बस ठीक है.
Perfect, sir.
Okay,
Yes, sir.
okay. Flush करो करो. Guiding check करो.
Guiding. ठीक है. Guiding looks fine.
ताकत से दियो.
बताइएगा.
Okay, looks good, sir. इसको निकाल लेते हैं.
Hmm.
बड़ा भी आ रहा था.
Hmm.
So it looks like ostia. We need more work to be done at the ostia.
निकाल.
What it looks like in the longitudinal view, but maybe. आया ना पीछे. Okay, show the L6 ostia. I think we are
ठीक
covering
लग
the
रहा है?
ostia. Actually, we are our studs are there at the ostia. Can you just rotate? Go to L view. Yeah, L6. Yeah. So we have covered the L6
हाँ.
ostia. We have just there. It's all covered. The studs are there. And what is the LED ostial
उसका कुछ
MLA?
वहाँ एपोजिशन और
MSC कितना है?
एमएलए कितना आ रहा है?
हाँ कितना है? 8.37 and
प्रॉक्सिमली स्टड्स अपोज लग रहे हैं. दिखाना जरा पीछे. क्योंकि उसको और करने में.
नहीं एक्चुअली हम लोग पूरा
हाँ.
L6 ऑस्ट्रिया कवर
हाँ.
हुआ है
हाँ.
हम लोग का तो शुड वी डू समथिंग और
रीक्रॉस करके बलून
नहीं क्या कोई ऑस्टियम उसका एनजीओ
पिंच
में
तो
देखो.
नहीं हुआ है.
बट स्टार्ट हटा दें वहाँ से. मतलब
सीने
रिक्रोस
एक 16 करना.
एक साल का है
दिखाओ. सिस्टम ठीक तो लग रहा है.
बिकॉज दिस इज
दिखाओ.
ओपन सेल है.
ये तो हम रिक्रॉस करेंगे अगर इसको तो मैं ऊपर ओके
8 6
आउट.
या परफेक्ट नाउ इट्स ओके. See, that's the challenge when you have a roomy left main with a big LCX coming from there. So
इसको निकाल रहा हूँ.
इसका डेप्थ वो करना कम और बढ़ाना.
हाँ इसका
तो इसमें आएगा साइड से. या ओके. Just show the left main part जहाँ हम लोग को थोड़ा सा malposition दिख रहा था. Did we able to do something or is it same? Not much difference. हाँ? Not much difference. ये कितना कितना है ये लेफ्ट मेन तुम्हारा कितना बता रहा है? 5 के ऊपर होगी ये. तुम लूमन 5 बता रहे हो ना कितना बता रहे हो ये?
5 का देखो.
That is a lumen 4.54. अंकित पहले ही पकड़ लिया. 12 तक. Okay. Stay there for 20 seconds, I think.
इंजेक्ट.
Looks good, sir. अभी तो इसका तो अच्छा लग रहा है वो. सही आना चाहिए ना क्लियरेंस अच्छा हुआ है. Okay, let's see. We have done some difference or not.
So sequentially you first went with a 4.5 at a lower pressure.
Lower pressure, sir.
Then did an OCT run, found some malposition,
Malposition.
and then
We
upped it
went
to
up to
4.5.
Till 12, I think. So we
12.
went to
12.
nominal pressure, sir. Because the lumen area of left main was 4.6.
Correct.
So we had a leverage to go ahead with this.
And I think as you rightly said, after this imaging, you sort of start believing that ostial placement is not as easy as it seems on
As
a
it seems
fluoro.
angiographically, sir. So it's maybe would have done with left main to
Yeah.
LED.
Can we have like
So can you have the L6 ostia?
L
Did you
ostia
show
look?
that L6 ostia?
A flying view.
Is this the final view? नहीं मेरे को इसी में चाहिए 4.5 के बाद. Why? नहीं, बट उसमें फायदा नहीं ना, बिकॉज उसमें स्टेंट स्टड्स तुम्हारे
अब
दिख
दिख
ही
ही नहीं
रहे
रहे
थे।
हैं, हाँ।
चलो ठीक। सो आप बोले कंक्लूड करें।
बोलो बताओ।
So I think, sir, we imaging really helped,
Yeah.
and this was a case of ACS presenting us with unstable angina, having a LED critical stenosis in the proximal part, but there was an OCT showed a fibrotic
Fibrotic
lesion with
lesion.
a lipidic plaque and necrotic area, and we had a osteal lesion, but POC was totally clear of disease. There was no plaque in the left main, and we did an LED osteal placement. And again, imaging helps us in telling about what was the expansion. We didn't create any dissection in the mid part, in the distal part of the head stent. And the proximal, I think we protruded a little bit in the left main, which was unexpected because we thought we have just placed at the angiographically we were at the LED ostia. So
But
we
the
did
good
a
thing was that LCX Ostia was roomy
yes.
and
Yeah.
it didn't
So I think that
return
the
properly.
predictors also, which we discussed on OCT base, that there was less chances of side pass pinching, which helped us in that there was no significant narrowing or compromise of L6 flow. So
So
your
I,
concluding remarks, sir?
so I think, as you rightly said, the trade-off is between missing the ostium and getting a shade bit back inside the left main, which happened in this one. And so, after dilating with the post-dilating with 4.5, initially conservatively at 6, and then upping it to 12,
12.
got you a good lumen, and probably there was no significant malopposition at the end as well.
No, sir.
So
No
we
pal position, sir.
shall we take some final
Yes,
shoots?
sir.
भैया बस 2 मिनट हाँ.
So looks good angiographically
So
also.
then
There is
final
no
RO
significant
cranial.
carinal or plaque shift, and L6 ostia is totally fine.
Yeah, एक final RO cranial ले लो. Yeah.
Yes, sir.
Okay.
The neocarina didn't protrude into the circumflex at all. Only the struts were just
Struts are there,
there
so
across the ostia.
So one final
yes, sir.
thing without the wire. एक
Okay.
final thing without the wire ले लेते हैं. Yeah. So I'm pulling
I
out the
think yes,
guide.
sir. I
Yeah.
think
Yeah.
we are.
So thank you everybody. Thank you. Thank you so much. Thank you.
Thank you.
हाँ जी.
हाँ.
Sure. So the SGPGI team thanks all of you for participating in this case, and I thank the entire cath lab team, the entire resident team, Dr. Rupali, Dr. Ankit, Dr. Shanawaz, Dr. Arpita, and the imaging team. So thank you so much. Thank you.
Thank
Thank
you.
you.
जी वायर.
इसको ऐसे ही निकाल लेते हैं.
अच्छा ऐसे मैं वायर पे निकालती चल ठीक.
Hmm.